Hi, I'm Alicia Gonzalez, emergency physician and the director of clinical training at the Bridge Center, a program of the Public Health Institute founded to make it easier for people to access healthcare when and where they need it most. One of our main goals is to help people in our communities stop dying from issues related to drugs and alcohol use. It's no secret that too many people are dying from drug overdose or harm associated with substance use. And for us in the emergency department, we are seeing more and more patients struggling with alcohol or drug use on every shift. In fact, 1 in 4 patients who come to the ED screen positive for a substance use disorder. These patients are already coming to us for help, and they're a super high risk population. For example, patients who require naloxone to reverse an opioid overdose have a similar risk of death in the following year as patients who just had a STEMI. And that mortality risk peaks in the 48 hours following their emergency department visit. This essentially makes opioid overdose the unstable angina or TIA of substance use disorder. These patients are as medically vulnerable as patients we admit all the time for things like chest pain rule-outs or stroke workups. Don't worry, we are not going to admit every patient with substance use disorder to the hospital, but we do have the ability to do something to help. We can start our patients on medication that drastically decreases their risk of substance-associated harm and mortality. Specifically, those with the best evidence are medications for opioid use disorder and medications for alcohol use disorder. Years of addiction medicine research shows unequivocally that substance use disorder is a complex neurocognitive disease that spans multiple medical disciplines, including genetics, neurology, and behavioral health. Similar to obesity, diabetes, high blood pressure, and so many other complex medical issues, the solution is multifactorial. But the first step is evidence-based, life-saving medication. For alcohol use disorder, we can start patients on oral, generic, naltrexone, and gabapentin. These medications have been shown to decrease overall alcohol consumption, cravings, and mortality for these patients. For opioid use disorder, whether it be fentanyl, heroin, oral oxycodone, hydrocodone, both methadone and buprenorphine are very effective in treating opioid withdrawal and cravings, and they lead to an incredible reduction in mortality. But while methadone works, there are several regulatory and practical reasons that buprenorphine is a better medication for us to use in the ED. Buprenorphine, or BUP for short, is a partial mu receptor agonist. Patients with opioid dependence require some level of opioid in their system to allow their body to function normally, and buprenorphine successfully does that. As a partial agonist, bup has a ceiling effect on respiratory depression, so it does not cause respiratory arrest or overdose on its own. Bup also has a super high affinity for the mu receptor, meaning it does not displace when another opioid agonist is taken. This can provide some protection and resistance against overdose in the setting of relapse. Bup can be given as a long-acting injectable weekly or monthly dose, but typically for us in the ED or the hospital, we are starting patients on oral dissolvable buprenorphine, either a sublingual tablet or a buccal film, and it must dissolve in the mouth. The bioavailability of bup is lower from the stomach, so swallowing bup will lead to an effectively lower dose. Some formulations mix buprenorphine with naloxone, claiming that naloxone will blunt the opioid effects should a patient inject their bup. The reality is, bup has a much higher affinity for the mu receptor than naloxone does. So really, the naloxone will not blunt the bup response no matter how the patient takes their medicine. But the naloxone does get absorbed even with oral doses, and it commonly causes GI upset for many patients. In the end, it doesn't really matter which form of bup you prescribe. Your best bet is to choose the one that your patient will actually take, and ideally, that's covered by their insurance. When treating for withdrawal, bup has a long half-life, so it can easily be taken as a single once-a-day dose. However, the analgesic pain control properties of bup rise and fall over about 6 hours. So patients with chronic pain or who are more sensitive to the rise and fall of bup in their system may do better with their bup divided into a multiple dose per day regimen instead. While bup is safe and simple to prescribe, honestly, the best part about it is that treating opioid use disorder with buprenorphine works. The number needed to treat with buprenorphine to keep patients in treatment for opioid use disorder is 2. 2 people. That's a better NNT than many standard practices in medicine, like steroids in a COPD exacerbation or even aspirin in a heart attack. What's more, recent evidence demonstrates that 1 in 9 patients prescribed bupe from the ED remained engaged in continuous, uninterrupted treatment at 6 months. Results similar to or better than other high risk conditions like, again, COPD. Unlike methadone, there is no special waiver or certification required for us to prescribe buprenorphine to patients with opioid use disorder. Any clinician with a DEA license covering Schedule III meds can prescribe buprenorphine. This means patients can have a prescription for home and they don't have to go to a clinic every day to get their dose, which makes their life much simpler and their treatment far less complicated. Buprenorphine is safe in adolescents, adults, and pregnant and breastfeeding women. And starting your patient on buprenorphine is basically the same process regardless. So, how do you start a patient on bupe? Well, first, wait for your patient to be in moderate to severe opioid withdrawal. Then, give the patient between 16 and 32 milligrams of buprenorphine. Please note that doses smaller than this are really not adequate for the majority of patients with opioid use disorder, especially if that patient typically uses fentanyl. The correct starting dose of bupe for patients in opioid withdrawal is 16 milligrams or higher. Recheck your patient in 30 to 45 minutes, and if they're still experiencing any withdrawal symptoms or cravings at all, give another dose of buprenorphine. Keep doing this until your patient feels better. Don't forget, you can still add other supportive treatments to help with symptom control, like NSAIDs or antiemetics, clonidine, and even a single dose of benzodiazepines to help with anxiolysis. Once your patient is out of withdrawal and ready to be discharged, write your patient a prescription for buprenorphine, typically 16 to 24 milligrams per day, with enough doses to bridge them to an outpatient addiction clinic. Depending on your community, it can take anywhere from 3 to 5 days to 2 to 3 weeks for patients to have that follow-up appointment. So make sure that your patient has enough medication to actually get them through that time and to self-titrate their dose in case they have breakthrough withdrawal symptoms or cravings. That's right. I said self-titrate. Studies have shown that patients are as capable of managing their buprenorphine dosing as we are. And in fact, they can even self-start bupe without us there. So if you're seeing a patient who is not yet in withdrawal, but they struggle with opioid use, you can send them home with a prescription to start bupe on their own. They simply wait until they're in moderate to severe withdrawal and then follow the same protocol we just went through, repeating doses of bupe until they feel better. There are ways for patients to start buprenorphine without entering withdrawal. This is typically called microdosing or cross tapering. But that process is a little bit more complicated and typically best reserved for patients being admitted or those with a high level of health literacy who can successfully follow that protocol on their own. One of the most common questions we get asked about starting patients on bupe comes from concerns about diversion. What if my patient sells the bupe that I prescribed them? Or what if they use their bupe inappropriately or share it with other people? In 2019, the Journal of Substance Abuse Treatment published a review of 17 studies surveying over 10,000 people who had used illegally purchased buprenorphine. And what they found is that the majority of those people were actually trying to be in treatment for chronic pain, withdrawals, opioid cravings. They needed treatment and were having difficulty accessing it through the healthcare system, so they turned to illicit sources to find it. And in France, in the 1990s, they were experiencing alarming rates of heroin overdose death. So the French government intentionally worked to educate their doctors on buprenorphine to treat opioid use disorder, and they got rid of barriers to prescribing. Even as they estimated about 20% of prescribed bupe was getting diverted. And you know what happened? People stopped dying. We cannot let the fear of diversion be what stops us from starting patients on medications for substance use. Diversion just means that our patients don't have access to the medication they need through the healthcare system from us. We need to make treatment easier to access than illicit drugs. Only then can we stop patients from dying. This is more than just another initiative or one more problem being pushed onto the ED to solve. This is about us catching up to modern medicine, making sure that the best evidence based treatment for one of the deadliest chronic diseases of our time is available to every patient that needs it wherever they're seeking care. Medication is the standard of care for opioid use disorder. This is the emergency medicine model, which was the inspiration for the bridge model. First, identify the highest risk patients and stabilize their emergency by providing low barrier, life saving medication to stop withdrawals and treat opioid and alcohol use disorder. Then, help our patients connect with the appropriate next destination for them in the healthcare system. This can be best done by navigation services, where navigators receive specific training that allows them to optimally support these patients through the process of establishing outpatient substance use care. Finally, we must emphasize a culture where our teams are equipped with the skills to help all patients who use drugs or alcohol reduce the morbidity and mortality of substance use. This is, first and foremost, starting medication for patients who need it, but it's also distributing naloxone, talking with patients in plain language about reducing the harms of substance use, and rebuilding trust with a patient population who has largely had a pretty negative experience with healthcare in the past. Medication is truly the standard of care for patients with substance use disorder. And this time, the right thing for patients is also the easy thing for us as clinicians. Make medication for opioid and alcohol use disorder the standard of care in your hospital. And let's work together to save some lives.